back us up. Back us up. There we go. I get nervous when I see us big. Good morning.
Good morning.
How are you?
I'm great, and yourself?
Fabulous. Fabulous. Okay, let's get all this stuff together. Let's get this. Wait a minute. What did I do? No, we don't want to do that. Okay. I'm pushing buttons that I shouldn't be pushing. I see that already. All right. All right. Well, it's Saturday morning. Okay.
Yeah.
We're oh, hi folks in the room. I'm like, okay, the room is light. What is happening? Like I said, I don't know if it was me, but none of the stuff when I first popped on Clubhouse showed up. And I was like, where? That's what I use as my test. I'm like, where the groups? Where the people? What is happening? I don't know. I don't know. Maybe folks, like you said, they out, even though these numbers are up. Why are y'all still out? So it's a hot girl summer, hot boy summer, I guess, still. Okay. Well, welcome to our Saturday morning tea where we discuss health information, news, education, certification, entrepreneurial, all the tips. And we're spilling all the tea. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co host, today's episode is brought to you by the Professional Reimbursement Network. 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right. So if you are on Clubhouse and you are interested in the 5 steps to become a certified marketable medical coder, then you can check out the link at the top of the page. Also, if you are on Facebook and or YouTube, you can check out the information in the description box. So joining me today and every Saturday, thank God, is my illustrious co-host, Mr. Jesse, the registered trademark. You better do it. The coding nurse. Sir, introduce yourself and tell the folks all about you. I can't hear you. Good morning, Vicky. You're muted on Clubhouse. There you go. I'm like, wait a minute, sir. We was just having a conversation.
Exactly. Good morning. My name is Jesse. I live in Philadelphia, Pennsylvania. I've been an LPN for 29 years. About 14 years ago, I transitioned in 2014. I transitioned into the world of medical coding, and during the pandemic, I created a company, the Coding Nurse LLC, where I help nurses and other uh, healthcare professionals with direct care experience to transition into the wonderful world of HI.
Cool. All right. And we're so glad that you did. We're so glad that you did. So if you are on Clubhouse and you want to join in on the conversation, please raise your hand. Don't be shy. Your opinion matters and is welcomed here. Also, it's a little training opportunity. So if you are, especially if you're new to Clubhouse, and you've never done any of the behind the scenes types of things, you can come on up to the stage to see what that looks like. For my Facebook and YouTube friends, you all know what to do. You hit that the comment or the chat to provide information there, such as what my girl Vicky does. So she says, hello, good morning, everyone. And we'll spotlight your comment. If you have a question, you can also place your questions there, and we can. It's easier if you put a Q in front of your question. That way, we know it's a question versus a comment. And then don't forget to use the hashtag Saturday Morning Tea. Yes, I think we need to start branding that and putting that out there in the atmosphere. We've been here long enough. What, 39 episodes? 39 episodes. Crazy from whence we came. Okay. Well, let's get started. Whew, I don't even know where to begin. I guess you begin at the beginning, or yeah, I'll say it that way. My friend said it's beginning real crazy, and never mind. I was going there, but I'll hold on. All right, so I guess first, I'll talk a little bit about the codes. So the ICD-10 codes for 2023 are out and up in the world. And did you know how many codes there were? Oh my God. There is a lot of stuff going on. There are 1,176 new codes for 2023. And that's just the diagnosis codes. It's not as many PCS codes, but that's a lot. So we early in the process, or lightweight early in the process. These codes go into effect in October. They're everywhere. So if you're coding in certain specialties, like there are a lot of things going on in cardiology. There's some changes. There's a lot of stuff going on in cardiology, actually. There are several changes there. If you're doing anything related to neurology, there's a lot of brain things. Dementia codes have been expanded. There's musculoskeletal things going on. One that you probably see a lot, ventricular tachycardia, especially if you're in cardiology. There's a new code for unspecified ventricular tachycardia. So check that out. OB has some new codes in their world. Endometriosis codes are broken down by site and now depth. Let's see. I said neurology, traumatic brain injuries. Poisonings, adverse effects. It's a lot of stuff going on in the external causes section. I know that's your favorite. So it's a lot of stuff going on there. There's 9 new personal history codes. So UHCC folks, be careful with that if they're talking about something and it's really a personal history, so that you don't code it and get in trouble. There are 14 new patient or caregiver non-compliance with dietary or medication regimen codes. It's a lot going on. So make sure you take a look so that you are prepared when those things come down the pike. So that's the one thing. Anything you want to add to that? And I think I talked before a little bit about some of the guidelines that they were proposing.
I didn't know that it was going to be this expansive, because I just completed some CEUs for my home health credentials, and I saw just the changes they were making to dementia as it related to home health. And I'm like, wow, they have really expanded it a lot. And there's also there will also be new guidance around underdosing. Because now the provider would have to document like an exacerbation of a condition in order for you to code it as an underdosing effect. But they were saying that as of October, provider documentation is not required, as long as it is documented that the person is taking less than the medication is ordered. You can code like the disorder.
Oh, okay.
I'm like, oh, okay.
Okay, well, look at here. Right. The games that they play. No. Well, they're all about that documentation burden, as they say, that on these providers. And so yeah, I'm still with the information that's come out regarding E&M. I'm this gonna be a doozy. This gonna be a, I don't know. I did a video on it. I don't. I don't feel like they're given enough uh time and education to it as they did with the office and other outpatient services. Because and I know that there are providers that only provide services in hospitals. They don't have their own private practice. So this is new to them. So I think they should have got the same level of information and prayerfully education as the other ones, because it's a different little twist to it. Um yeah, so that's gonna be real interesting how all that falls out. And then I guess what, 2 years from now, once they feel like everybody is comfortable in being in one bucket as it relates to their documentation, the audits will come. they'll they'll hit the scene. So that was one topic. The other topic, I had never heard of this. I don't know if you had. It was I just happened to come upon it, as I do when I'm looking and searching and scouring the interwebs for information. And they were talking about single path coding. And I guess I know what it is. I just never heard that term before. So, but it's a whole thing. So, had you heard single path coding before?
No.
Okay. So, single path coding is pretty much, and they're I guess I won't say experimenting, but they're piloting. I'll say that. They're piloting it in the outpatient arena. And so it's where they're taking, currently you could potentially have a coder who's doing and providing the services for coding the outpatient services that may be happening. And then you can have a coder that's providing the professional services that may be happening with the provider in those outpatient settings. Because you got two, pretty much like in a hospital clinic, you got two things going on. The facility is going to get their money and the provider is going to get their money. And usually you have two separate coders that are providing the coding for those. Well, they're trying to put it together. They want one coder to do both. And so that's what they're kind of looking into and pushing for, if you will. And I saw 3M was in the mix, because for them, it's now putting together the tools to make this kind of seamless transition. And I was like, okay, I get it. So again, they talked about, and they're billing this to or promoting this to hospital executives, the finance people, CFOs, the whoever, because they're facing financial challenges, and they want to kind of say, hey, well, we want to use and in one of the articles, it talks about using the old adage of work smarter, not harder. So they want to just have this as an option to allow them single path coding and tying all of them together. So it's one coder, combining both the facility coding and the professional coding. And so I was like, okay, now, my first initial thought was, well, first y'all want AI to come in and take over. Now y'all want to reduce the numbers by, combining. However, I know in my courses, I always tell people it's not an or thing, it's an and thing. So get information on CPT and PCS. Get certifications for AHIMA and AAPC. Like, don't don't limit yourself and don't put yourself in a box. And I feel like this is another way, unfortunately, that they're moving, that's going to force you whether you want it to or not, to get that information and knowledge on that. It the article that I looked at, oh, I forgot to, I'll link them in the on the YouTube video. I guess it'll show up on the Facebook as well, but I'll link the articles there. This one was from Courtney Crozier, and there's another one from the Health Information Associates, and that was from Patricia Maciarella. I hate that. I'm going to butcher that name. Haffy. Even though I've seen her before. I've seen either articles by her, or I've met her, or I've seen her somewhere before. But anyway, and so it talks about that. And then she actually goes into speaking to like the takeaway for coders. And again, it's back to pretty much just making sure they are well versed in understanding both areas. So because there are certain modifiers for facilities that don't apply to providers, and vice versa. And so just making sure folks entertain certifications in both areas. And so a person who has multiple credentials, but that are diverse. So you have your inpatient credentials, you have your outpatient credentials, or provider credentials. It can be a win-win in that regard. And so that's going to be interesting. I think that also will change some of these. Well, we'll see. I'm thinking some of the coding programs, because a lot of them are focused towards inpatient versus provider versus whatever. And maybe not. Maybe they'll if you're, maybe not. I don't know. What are your thoughts? I'm going on and on. What are you thinking?
The whole time you've been talking, I haven't really. I'm still trying to wrap my head around it, because it's just, I don't. It's just, in my opinion, it's just some more nonsense. Because what happens is, you. So a person is supposed to code for the facility and for the provider. So that's going to. So how is that going to affect productivity?
Right. Right.
That's the first thing I thought about, and then um, they want to, like, because when I was reading the article, I'm like, it's not like they're two separate skills. Like, I mean, well, there are two separate skills, but it's all under the umbrella of coding.
Correct.
So you don't need any specialized training.
Correct. You just need to know what is appropriate, right, for the setting that you're working in.
But the industry has made it so you have to pick a lane and stay in it.
Correct.
And the industry is the reason why they have articles like this, because they don't allow people to cross train. They don't allow people to switch paths. Like, it's very hard to go from professional to facility and vice versa. Once you are there, you're pretty much stuck there, and it's ridiculous. So now that they have this, just because you call it single path coding, so what does that mean? That means that starting next week, there's going to be all kind of job opportunities available for coders. I don't think so.
It's actually I think it's going to make it worse, but especially if you're looking for that. I mean, and they exist. Don't get me wrong. There are plenty of folks who have expertise in one or the other, but because it's not the norm, they're usually sitting in a lane, and they've been building their expertise in one particular lane, and not necessarily the other. The only other ways that they possibly utilize the other is, like you said, when it's time to get the CEUs, and you're like, oh, wait, let me go over here and check out what's happening on the facility side or the outpatient side in order to do that. I don't know. I think it's quite interesting for a couple of reasons. I remember way back, gosh, 5, 7, 8 maybe years ago. when and they did do it when the Mex came together. So you used to have a fiscal intermediary, and you used to have, oh, I can't even think of what the professional side was, but you used to have two different areas that would look at Medicare claims. So they would take a look at what was happening just on the facility side, and then the other ones would take a look at just what was happening on the provider side. And then they brought them together. And that was a big to do, because it was like, oh, now we have the data where we can look at what's happening on either side. So when we get this one claim for a facility, we also will look and get the claim for the provider, and we can match them up and see, okay, well, what are they talking about, and what are they talking about, and what are they what does this claim look like versus this claim, and are they adding up? um I, this may be a way to kind of, I don't know, streamline that. uh, I don't know. I'm feeling something in my spirit that this is because if you have the one versus, okay, I don't necessarily need to go find another coder or have a conversation with somebody else about, well, what did your provider do? And what did your provider do? Well, we're doing this and our claim looks like that. I mean, granted, it's going to be still on two different claim forms, but I guess it's just the one person. But to your point, somebody would need to check these productivity levels, because now you're doing the work of another coder. You're doing two tasks. You're doing multiple things. And so it's going to take a while, more time, more energy to make sure that those claims, because per every encounter, now you're looking at coding two claims, so it's a 2-for-1 going out the door. So I don't know.
And what I also think is, I think that when they want to talk about single path coding, you're gonna have it so people are gonna have to have a facility based credential and a professional credential.
Right.
And so somebody who has a CPC now, they would have to get a COC, or even get, well, and or a CIC. You would have to have two, because the only one, because when I was thinking, like, I mean,
Or on the AHEMA side, you will have the CCS or CCSP.
Well, if you like,
because they need the PCS
right, but
potentially.
the CCS, for example, is comprehensive. Like, it's always been, you have to know how to level physician services, and you have to know facilities. You know, facility coding, because you have the ambulatory patient classification, like all those, the X's, the S's, all that is facility based.
Uh-huh.
You know, the S code, the T code, like the T being subject to multiple code discounting, the S code is not, and also even in their prep, even though it wasn't on my exam, you even had to level facility ER visits, where you had to, they would tell you like the number of trays that was used, the number of diagnostic tests, so have to add a modifier for a modifier 25. So it was just, the CCS has always been comprehensive, where you get all of that. But on the
Right, but if you didn't get your CCS and you only have the CCSP, which is for the professional side, then that's where you would need to get the other on the AHEMA side.
Right, and then you would have to have, so basically people are going to have two credentials.
Yeah, she pretty much you're answering her question. And it's, yeah, and I saw you're certified. She said she meant certified instead of verified. But yeah, I would think so. But go ahead. I'm sorry. I didn't mean to cut you off.
Because right now there is no equivalent by anybody for the CCS. It's pretty much its own little entity.
Uh-huh. And I think AAPC, they tried it. They tried it, but I don't think they had enough inpatient folks involved to yeah, they tried it.
Because with them having, I've always, I mean, I give them credit, because when they came out with the CIC, I'm like, that's nice, and they're all, they're trying to. I get what they're trying to do, but they have been so known for outpatient. I just, I don't know. And I have seen jobs that do list it as as a potential qualifying credential. So people are accepting it, but I just don't know how many people actually get it on the AAPC side.
Yeah, that's interesting. Well, I'm like, especially as it relates to HR, because that's a whole other argument we've had over and over again. The more information and knowledge they have about the credentials, I think is a win-win for us, even though they may not necessarily put them in there right, or have it uh, correct to the position that they're soliciting. But the more that they know about them, the better. So I mean, baby steps, I guess. Baby steps. It's there's still a lot of ads out there that's saying ICD-9. So Lord, if they can get a credential right, yay! I'll celebrate the small wins.
But and speaking of that, I think that it is so important that, and I think that it's up to the coding industry to put pressure on these HR departments, because what I've noticed is people will get credit in ads. You will get credit for having an RHIA, an RHIT, for having an RN, for being an MD, but you don't get any kind of credit for having a CPC or having a CCS. Those are like requirements in addition to these other things. And correct me if I'm wrong, but every time when I took my CCS, my CCSP, and all these, it says in writing, these are mastery level certifications.
Mhm.
So if you have attained that level of certificate, if you have attained mastery level certification status, that should account for a certain amount of time in the marketplace, and it doesn't reflect like that in ads, and I just don't think it's right.
I agree. I think the only reason why I think that they carve those out, um, particularly the RHIT and the RHIA, is because that shows that you've received a degree to get those. And so I think they're connecting those in some kind of way to a degree. That's the only thing I see, because again, there's no specialty learning in RHIT or RHIA. You get the specialty, the mastery, particularly for coding, um, with the uh, credentials, the certification credentials. So yeah, yeah, you're right. You're right. There should be some credit. Vicky asks, she said thanks, and would CCA also be both worlds, but in a beginner level?
No.
They don't give you both in a CCA. You don't.
I don't I don't know anybody who has gotten a job as a CCA. I mean, I don't even see it even as an acceptable credential.
Really?
Hmm.
I tell folks all the time, if you have been all in the professional, so if you have your um CPC and interested in knowing what's happening in AHEMA and want to put your foot out there, and if you don't feel confident enough that you have enough to go for the higher levels, I always tell them CCA is an option.
But what do you do with it?
It's a coding credential too. It's just a beginner level. It's just like
I
somebody with a CPCA.
I get it, but at least they even have a hard time finding jobs, because you see it everywhere. CPCA not eligible.
Now I'm saying I combine them. I'm not saying have it. I don't know too many people that just got CCA by themselves. I don't that I don't know. I'm saying combine them. So again, remember I said not or and. So if you want a credential in AAPC and one in AHEMA, the CCA is always a good place to start. If you don't feel confident enough to, or don't have enough experience or knowledge about the higher level, the CCS or CCSP. That's all I'm saying. Now, really and truly, honestly, that CPC and CCSP should cross paths. um, and again, it's just folks' comfort level. Now, really, that's the one that should connect. But some people don't feel confident in that manner, and so I said, well, if you don't, then start at the beginning and work your way up. That'd be my 2 cents. But yeah, so I just thought this whole single path coding thing was interesting, and I guess they're going to be more. And these are these are articles from this year, so I guess other entities will be speaking to healthcare executives and showing them, hey, this may be a way to streamline your departments, and this may be a way to uh, have you work smarter, not harder, or whatever. So yeah, it's gonna be interesting. It's gonna be interesting how they pull that, and then if they will be able to find the staffing for that, because again, to your point, there are not a lot of people that are right now working both. You're either working one or the other. You may have multiple credentials, but you're not necessarily working both, unless you're a consultant. Consultants may be doing it. I think that's probably the one place where that's popping off, because you can kind of, depending on who you're consulting with, you can go kind of back and forth and sharpen that iron. I don't know. I just thought that was some interesting reading that I wanted to share that's happening in our profession.
I mean, it is interesting because they're going to have to really, really revamp education around coding, and they're going to really have to be careful what they tell these students and how they advise these students moving forward.
Yep, that's a whole other piece of it that you are absolutely correct. That's going to change the whole game, because folks hear one thing or the other, because I remember inpatient, I was like, Lord, that was a lot. When you're coding inpatient, you're coding those volumes. Now, I don't know, the facility, outpatient facility, it's not as bad, but there's still a lot of things from the facility that you got to account for that you don't necessarily have to do on the provider side. So it's still a lot of making sure you check over here, making sure you check over here, making sure you check over there, so you don't miss anything. Where with the provider, it's kind of straightforward. A lot of people strayed away from the provider side because they couldn't get with E&M. E&M, baby, folks would be like lost, looking in the land of the lost, just deer with headlights lost, trying to do E&M. So that's why a lot of people stayed away from that. But which I love. I love E&M. It's like putting a puzzle together. I love it. But anyway, yeah. So I think it's gonna be interesting. It's gonna be interesting. And to your point, on the education side, like making sure that these programs actually include, and we talked about that last week, actually include information on all of the coding systems. They got to know, not just a cursory, oh, this is out there, this is whatever. No, you're gonna have to dig in and prepare I would think, if you want to make sure you have a well-rounded student. Remember that certified marketable medical coder, a well-rounded person, making sure that they know, hey, you need to have a working knowledge and understand how to do PCS. You need a working knowledge and understand how to use CPT and even HCPCS. I mean, just all of them. And so it's gonna change the game. It's gonna change the game.
I'm curious to see. I'm just, because it all sounds good now, but we'll see.
Oh, it's gonna be drama. and on our side, the auditing the reviews that will come from it, that's gonna be quite interesting too. So yeah, it sounds like the answer on the front end, but let's wait and see what it looks like on the back end, and remembering that it's all part of the whole um revenue cycle and what that looks like. um yeah.
So, well, I got an interesting email yesterday,
Okay.
and actually, I got an email, I got a LinkedIn message, well, several from the same person,
Okay.
which was kind of odd. So, I mean, because we are connected on LinkedIn. So, long story short,
Mhm.
this person is a CPC and is working, but had reached out to me because they needed more, they weren't as confident in CPT. So I'm like, well, that's where you find some continuing education classes to bolster it.
Mm-hmm.
And then she had commented on one of my YouTube videos that I did on medical coding and data analytics.
Mm-hmm.
So she was talking about how she wanted to get into data analytics and she wanted me to give her some information on how to data mine CPT codes. So I'm saying to myself, like, wait a minute, who data mines CPT codes? Because people data mine what pays. And unless you are, I've just never heard of anybody data mining CPT. Unless you're doing maybe some kind of like detail, like something for auditing, I could see it. Because you would have to audit a lot of professional service, or if you're doing pro fee, okay, well you do need CPT.
Mm-hmm.
And then CPT is so broad. Like, are you talking about procedures, or are you talking about E&M? Because that's, but I've just never heard of anybody data mining CPT because most people data mine ICD-10 CM because that is, especially well inpatient, that's what the payment is based off of, and an outpatient increasingly more and more with these value-based programs, you know, risk adjustment is becoming more and more. Now there are just like an inpatient, there are inpatient procedures that can increase the DRG. There are outpatient procedures that can increase your score for certain things. So I don't know. Maybe it was just using the wrong terminology, but I was like, who data mines CPT codes?
So they do. um like your surgery centers, your ambulatory surgery centers, your um um you have your APCs that are
Okay,
like
now I can see that. Like, that's for
your
auditing. I got
DRGs,
that.
correct?
That makes sense.
So where your MSDRGs are and all of that is for your inpatient side, there is a world that's connected to the CPT codes and the value and the dollars related to that. So you have that. You also have um, for physicians, a lot of them are when they're usually when they're joining bigger systems or being employed by bigger systems, they're looking at their RVUs, and so they're tying the CPT RVUs to their salary, or more or less their bonuses. So they're saying, oh, last year, we got X amount of RVUs, la 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 la. That's a base for a lot of these organizations and health systems when they are sitting at the table and having conversations with these providers. Because then due diligence is going to have them take a look and verify and validate that, like, okay, well, you said all of this, and yeah, you may have billed all of this, but what did you actually get back? And so that's where they do kind of a claims review of the different providers before they sign them on, especially if they're taking over a practice. So not necessarily one off individual, but if they're taking or acquiring a whole practice, then they're doing those types of due diligence reviews overall. And so they're looking at those RVUs and potentially APCs if it's a surgical practice. So yeah, they do that. We got that in our world too.
Okay, so she just wasn't clear about what it was she wanted.
Correct.
Okay,
Correct.
understood.
Yeah. Yeah. Our APCs are kind of similar. They tie.
Because I did know that I knew that much, but I'm like, but I just never. You don't even really hear people. You don't. Well, people just don't talk about CPT as much. I guess in certain circles.
Right. So if you're in the hospital circle, no, no. If you're morphing over into like the clinic of a hospital, you getting a little sprinkling, and then definitely in the professional world, you're getting the sprinkling. Or if you're, surgeries, um, um, surgeons, the surgical centers, all of that, and that's another thing. I mean, which is gonna be interesting. It just kind of hit me going back to that single path coding thing. So there's medicine is going to look different. Well, it's looking different if you kind of look at it now, because they're going away from inpatient care. They only want the sickest people in the hospital. They only want to deal with people who are truly ill and provide the services for them. They're moving things out of the hospitals, the inpatient setting. So they're moving them to surgical centers. They're moving them to home health. I mean, or other long-term care facilities to receive some of the treatment that they used to receive and or care that they used to receive inpatient. So, they're pushing things to their providers, their primary care providers, to, all of this care coordination and all of those things. So things are shifting towards the outpatient. Now, hospitals are never going away, because you always have people who have a need for hospitals and the services in hospitals. But just know that, it's been happening for years, and folks have been talking about it for years, that things are shifting away from. And so they're putting and well making sure that those infrastructures are there to support that shift. So yeah. So make sure you pick up a CPT book today. No kidding. Thumb through that CPT book, sir. I think I have mine right over here. No, that was the other one that's upstairs. Like, yeah, because somebody was asking me some. Oh, it was he. This is a long story. I'm helping a client with some implementation into a clearinghouse, and well, one implementation into a clearinghouse, another one into a whole EMR. And so working on that side from the IT piece, they want to map this and map that. And so they asking me, well, what about the CPT codes for this, and what kind of services they do for this? So I'm having to map and I'm like, you know what? This is crazy. But it provides me an opportunity to see all of this from all different vantage points and different sides. So I appreciate it. I appreciate it.
Because usually with the EMRs, you can just you can put in your commonly used CPT codes, so they pop up.
Correct. Correct. And that's what they were asking. Well, what is the CPT? But so again, this is dealing with behavioral health. So you got different players and providers, and I guess it can be used, the same situation can be used for others. Certain providers can only bill for certain things. And so and then there are certain services that everybody can bill. However, there are certain modifiers that are linked. And so that modifier tells you what type of provider it was, which tells you what the price point is for that. And so, and then he didn't understand that part. And I was like, so am I gonna have to put a line for each and every one of these? And it was like, no, the way it's mapped, if we have the provider in there, then we would link it to the provider. Then you would just make sure that the modifier is added, which will automatically, because behind the scenes is also a list of the procedure per provider, to the modifier and that price. And so once you click all of that, it will should seamlessly bring it over to the claim appropriately. So it's already listed there based on who that provider is when they drop that claim. So I was like, okay, well, we'll see. But yeah, so it's interesting. It's interesting. Like, okay, I see it. And then the other thing I saw, biller beware, that there was a biller that then got smacked with some convictions for over $600 million healthcare fraud, wire fraud, and identity theft scheme. Now, some of it is blatant and egregious, but a lot of it was overcoding. But the point being made is this person, and I don't know, was he convicted? So if he wasn't convicted, let me just make sure I say allegedly. But um, owned billing companies and was just doing all kinds of things. He was stealing from insurance companies and businesses. He was just, just fraudulent. And they made it real clear. The Attorney General in the Justice Department's criminal division had a quote that says, "This conviction shows that medical billers who fuel healthcare fraud will be brought to justice." So anybody out here that's in this medical billing and doing your own thing, make sure your stuff is tight. Please don't play. Please don't play. It's a lot of money out here. It's people hear those numbers and they see all this money. Oh, I saw another thing recently about the government and their contracts with small businesses and how much money is that actually what that looks like. I'm like, oh my God. So people might see that and they be like, oh, I can get in. And then they start doing some things that you're not supposed to do. No. So yeah. And his primarily the thing as a medical biller was he was submitting claims for procedures. He was upcoding. He was, they were either more serious or in some cases entirely different than what the provider actually performed. So there was a lot of upcoding going on and other things. And he got caught. Millions of dollars. And he got caught. So be careful. Make sure you're doing the right thing. Integrity matters. Don't just do it because, do it because it's the right thing to do. Do it because the right thing to do. You have anything on that one?
It can't be worth it because you're going to be caught eventually.
Mm-hmm.
And when they catch you, they're going to throw the book at you.
Mm-hmm. Yes. I was like, whoo. That was a doozy. And so, we always hear about providers, well, usually physicians, and you hear about because they thought they were above reproach too. It was CEOs, they getting the business. CFOs get the business. Now billers are getting the business. Coders potentially could get the business. Everybody can get the business if you're not doing the right thing. So just make sure you're doing the right thing when you are out here dealing with the government and government funds.
And it's just so sad because it's just such a wide range of knowledge out there. It's not like everybody is operating from the same base of knowledge. Some people know, and they're just manipulated, and some people really just don't know. And of course, the onus is on them to find out.
Exactly.
But it's even hard because I know, like, I've worked places where these companies, instead of doing the right thing, they'll find somebody who is a coder, or they'll find somebody who is a biller, who will do things their way, and then it becomes the right way, and it's not.
It's not. It's
And
not.
then it just messes everything up, and
It's
they don't get it. Like, just I I've never seen it. Why is it so hard to do the right thing? Like,
right. And and to your point, you know, unfortunately, that's even not even a good defense. Oh, I didn't know. Well, you were supposed to know. Before you sent that claim in, somebody was supposed to know. Somebody was supposed to do that additional research to understand this is how you were supposed to do it and this is why you were supposed to do it, which is one of the reasons why I feel like, because I know when I sometimes when I do the videos, especially this time of year when we're talking about what's happening in OPPS, in the outpatient prospective payment system, the inpatient prospective payment system, the physician fee schedule, sometimes I wonder, like, should I really do that? Should I provide that information? Should I say something about that, or should I stick to, just the tried and true? Okay, let's talk about codes. Let's talk about that. But to me, it's important to know the why and the machine behind why you're coding, why you're doing that. And oftentimes I remember being in a facility and you don't get that information. I wasn't getting that information directly within my department. Nobody was saying, hey, this, that, and the other. Every now and again we would have coding meetings, and like when the coding clinic would come out, they would circulate it and everybody have a couple of a day or two to kind of read it and sign off that you saw it, because that was the proof. Because if you did something wrong, it was like, oh, wait, you should have known, because you had, but you only got a day because they're, everybody chomping at the bit trying to get it. And I'm like, so again, I'm dating myself. This was all what everything was paper. So we was sending stuff around. And I remember the little staple thing that had all our names on it, and you had to initial to show that you read it. So if something popped off and jumped off and there were errors, it was like, well, you couldn't say that you didn't know because supposedly you read the information that was being circulated. So every now and again you would get those things. Sometimes it would be something that would raise itself to the level where the leadership would come in and just really have a deep dive conversation, like, okay, this is something brand new that is changing a lot of what we do. So let's take some time, carve some time out, and let us really go through this line by line so we all understand. But for the most part, they was just sending those things around. So I always wrestle with, is this important enough for on my end, on my time, important enough to get this information out? And I still every year feel compelled. So and which is why I do both. I do what was proposed. So because you have a voice. You may be like, why would they do that? This may be your expertise, and inside and out what is happening, and you may want to comment. And so I provide the information so hey, this is what's coming up, so be prepared. It isn't in rule yet, but this is what they're talking about. These are the things that are happening behind the scenes while you feel like my tried and true code may be here forever. It may not. And this is what's happening. So I provide that proposed, and then I come back and tell you, okay, now this is what's finalized. Because sometimes it changes. Not always do the things. They may get so many comments that kind of sway CMS, and they be like, yeah, we thought about it, and either one, we're going to make a modification to what we proposed, and we're going to do XYZ, or we might just put it on pause and we might just halt it. And there's several instances of that. And so those things don't go into the final rule. So I don't know. I just feel compelled to provide that information and be a resource to tell people, because a lot of just coders have no idea the machine behind what they do, why they do what that book that you get every year. Why is this book different? Well, here's the reason why. Because you got legislature and you got regulatory folks involved. You got all kinds of stuff behind the scenes that are pushing for and medicine, changes in medicine, and what is happening as medicine develops and new innovations are coming through. All of that combined is why they push this stuff every year. And we all saw with the pandemic, Because normally, it's a little slower process, but when the pandemic hit, that stuff was popping off damn near daily. It was like, whoa, like my head was on swivel. Like, okay, let me make sure they get this. Let me make sure they get this. Let me make sure they get this. Because sometimes people just your tunnel vision to your job, your tunnel vision to what it is that you do. You know what? I code these labs. Let me just code these labs. Let me just code these labs. Or, I'm inpatient. Let me just code these patients. Let me just code these patients. And not knowing that stuff is changing on a dime. Yeah, what you may be coding today is different tomorrow. My price today may be different. No, I'm kidding. But I mean, and so I continue to do it regardless of, I may be just talking to myself. I don't know, but I feel like that knowledge base needs to be out there, and folks should provide that. And it's a little harder to do that research because we're talking thousands of pages that there usually is some type of kind of cover sheet that kind of gives you, or executive summary sheet, if you will, that gives you like an overview. But then when you read that, there's always something that you're going to have to dig deeper. So I'm going through Federal Register, and I'm going, and because I need to see I don't necessarily care about what somebody else's opinion or thoughts or what their summation is. I want to see from the horse's mouth. So I'm going through the Federal Register. Let me see what they said, la 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 la. Because sometimes things don't match up. So yeah, that's why I guess I continue to do what I do. That was my tea for today. So I just feel like, you need to be armed with that. And so, this stuff comes out every year, every single year. Well, and now twice a year with your ICD-10. So I don't know.
Yes.
You got to be in the know. Be in the know. It's
really
this profession. When we tell you it's a lifelong journey, it's a lifelong learning journey, and you have to be one that's on it. And to me, it's interesting because then you get to see, the innovation. You get to see how things morph and change. You get to kind of put your feet and fillers into different areas. Like you mentioned, the data analytics piece. That's a whole other broader animal in and of itself, that as a coder, you have insight to. You have insight to the IT world. Like even seeing what I'm doing, helping them with this mapping or whatever. They don't know CPT. They don't know rules. They don't know guidelines. They don't know any of that. All they know is I need to make this machine do what I need the machine to do on the out. Which is fine, but you coder expert need to be the ones to kind of help and craft out what those workflows and paths and mapping and all of those things are. So I don't know. That's my little soapbox for today.
Well, speaking of soapbox, we had touched on data analytics. Can I tell you that is because all that comes under what they will call nursing informatics. And can I tell you, that is one battle that I refuse to engage in because I have tried. And it's like, you know what, go ahead. I have tried to tell people, I've tried to tell nurses, not people. I've tried to tell nurses because nursing is a way of thinking, like all professions.
It is. They special.
And right. And they have been ingrained that you have to have a piece of paper that says you can do something. It has to be a degree, not a piece of paper. Because in nursing, they don't really care about certifications as much as you do, because everybody's certified as something.
Right, and you can get your license as long as you get whatever, but that paper carries weight.
So it doesn't really mean as much in the nursing profession. But I try to tell nurses that nursing is to get a master's degree in nursing informatics is a scam. and there are videos on YouTube where they've had people who have gotten degrees and they can't find jobs because I tried to tell them you have to ask yourself if Amazon and Apple do not require a 4-year degree, but they require that you know these coding languages to this level of knowledge, and they're paying you $200,000. What do you think your broad nursing informatics degree is going to do for you in the marketplace? Nothing. Because Once you get into IT, it is about specificity. What skill do you have? And I try to tell because I've looked at the curriculums and it all sounds nice because they're talking to nurses and they just blowing smoke. It all sounds nice that you have a broad knowledge, but broad knowledge does not get you employed in IT. Specific skill sets get you employed in IT. Because, for instance, you can go into data analytics, you can go into security, or you can go into another one, security, oh, applications. So if you wanted to go in, for instance, if you wanted to go into applications, it would be the best way to go as a nurse would be to go and get your A plus network plus and security plus coding credential. I mean certifications
Mhm.
because then Epic would hire you because guess what? You know how to reset passwords. You know how this program is going to work on this network.
Mhm.
And you will also, since you have a nursing background, you could also train nurses on how to use this program,
Mhm.
this app. So that's a specific skill. If you want to go into data analytics, you do not need a nursing informatics master's degree for tens of thousands of dollars to do that. When you can learn the skills that you need, they have data analytics courses on Udemy for 19.99 that can prepare you for a Tableau certification or a Power BI certification. That's a skill that you can take and demonstrate to your employer today. Like you can actually go and interview and show them a visualization you created based off of data you found somewhere and just created a visualization over it. That's skill as opposed to you have this broad degree and then you still have to go somewhere and be trained to do your job.
Mm.
So
And the first thing that just came to my mind, and all of that you said,
mhm.
I have no sense on Saturday morning. Let me just say that. Let me preface this with that. So instead of spending that money on that bag, or spending that money on those shoes, or spending that money on whatever, spend a couple of dollars and invest in you and your education and getting those skills that everybody not getting. So that's how you position yourself. That's how you market yourself. Um, to these would be employers if you're looking to go into those areas. But to your point, it's about your skill. So even when we talked about this single path coding stuff that's maybe coming down the pike, again, it's about your skill. So getting the skills in the areas that may be unfamiliar to you. um Data analytics, babe, that's a big one. Even um your HCC coding, that's a big one as well. So there are other things that's out here that's popping. You got your folks that's coming in as entry level coders and just really interested in, they done heard somebody say, "Oh, coding is a great profession. Let me get in here. Let me make this money." But know, trust, and believe that that little bitty money that you saw that somebody making way over that because of the different skill level they bring to the table. When they come at the table, it's not just in this lane. They got several lanes behind them. Like when folks talk about multiple streams of income, you have multiple skill levels. You can parlay into multiple streams of income. I promise you, I'm a witness. So, just being tunnel vision and narrow minded about the opportunities out here in this game is detrimental to your financial life. So just make sure that you stay abreast of that. And Mr. Jesse, to your point, you don't necessarily have to have a degree to do that. Now, I am degreed, and I will tell folks, get degreed if that's where you need to go, because sometimes there are ceilings and they'll bump you, particularly if you're in organizations. Now, if you out here in the entrepreneurial world, your gifts will make room for you, and being able to speak to what it is that you do and how you do and the best that you do and your integrity and all of those things will make room for you. And then that's a whole other session and conversation to get you to that level. But if you're working within organizations and you want to move around or whatever, sometimes they hit you with that ceiling, and you bump up against that ceiling because you don't have a degree. I know, and that's not just in our industry. I think that carries in a lot of industries. I know a family member of mine kind of hit those ceilings. There was some transitions that they wanted to do, and they were told, well, you don't have a degree, even though they've been with this company 20 years. You don't have a degree, so you stuck here, and that's unfortunate in those instances. But again, you need to know the company, you need to know their culture, you need to know what's important to them, if you plan to stay and want to move and level up. And unfortunately, we run into those in hospital systems and the like. However, again, you build your skill level. You don't necessarily have to stay within that organization. You're valuable, and know your worth. Know your worth so that you can walk through various doors and entities, and then think about things that don't even exist. And I say this all the time. I tell people, stop asking these kids what they want to be when they grow up. Yeah, you put some tips and tools and ideas in their head, but guess what? The career path that they may have, or the job or occupation that they do, may not even exist today. And so don't limit them. Don't There should be no limits on what somebody can or want to do, because they may even be the one that's blazing that path for that particular occupation. So don't just say, oh, you should be a teacher or a doctor or a fireman or a policeman. Foolishness. No, 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 no. There are other things, even in those industries and fields, that don't necessarily exist. Like the stuff that we're doing, that stuff didn't exist when we were kids at all. And who knew? Hell, people are just now finding out that there's a whole business of healthcare. Folks like, well, when I think healthcare, all I think about is a nurse or a doctor, or somebody that's actually providing direct patient care. No, 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 no. There are people all. It's folks working in healthcare that probably ain't even stepped into a hospital unless it was for their family member or for themselves. So yeah, don't. There are no limits on that. Get your skills level. Invest in yourself. I guess that's all my tea for today, I guess. Huh?
And to that point, because here's what I've always told people. I'm like, okay, well, if you, instead of getting a master's in nursing informatics, you can go and get these skills. You can go and get these credentials. That's only a couple $1,000. If you want to get a degree, it's in something. If you want an advanced degree, the advanced degree for you to get would be an MBA. And I told them, because everything is about money.
Mm-hmm.
Every department has a budget, and when you get to a certain point, you're going to move up into that level where you're going to have to manage a department and manage a budget. So it's best to have those skills. That you could have a degree for that. That will do a whole lot more for you, because now when you look at people who are in these C-suites in these hospitals, they are accountants. They are people who know how to manage money, run money, and you don't find too many nurses, because that's not at that level. It's not about that. So I just, it's nothing wrong with education, but it just has to be the right education.
Correct.
And I
Correct.
think that's the only thing that gets me, because and I know, like, that's my profession. I know that these people are stubborn, and they have a one-track mind, and I get it. And I see it every time I have a class. I see it, because they have to, I'm at that point with this new class where, week after week they get their behinds handed to them, and they don't like it, because you want to read, because you want it to be what you want it to be. You don't want to follow the rules. You don't want to read the guidelines and do what the guidelines tell you to do. You can't fight City Hall.
Right. Right. So
And they in their feelings, like they big man. Well, yeah, I know how to do this. No, you don't.
If it was so easy, everybody would be doing it, right? Right. Amazing, amazing. But I love my profession. I think it's great. I
Oh, I
do.
do too.
I
I
love
just
it. I love it. There's so many opportunities out here. There's so many things. Again, I use coding as the stepping stone to whatever. And then, say I want to do something different. Say I need some home repair. Say I need something and I need to go make me some money, just like other folks do, make their money other ways. I can call somebody and be like, hey, I can code this or that or whatever, because there's plenty of people always looking for those types of skill sets and somebody to assist them in coding backlogs and all of those things. So I can always keep my skills fresh and new and stay ready so I don't have to get ready.
that's right.
While I pursue um other things that for me still has a base in coding. I was amazed when I one of my first public health courses, and they were talking about, well, it was, I think it was policy. I think it was my policy one, and they were talking about, because that was I was like, oh, this was like when I was a kid and I went to a German bilingual school. And when I was like, oh, I need to make sure my GPA stays on point. So I took German for years. I took German throughout elementary school. I took German in high school. And I was like, when it was college credit time, let me take some German. I got this. So this was the same thing with the policy, because then they were talking about, where the data comes for these policies, and folks didn't understand. And believe it or not, there are a lot of physicians getting their public health degrees. There are a lot of them getting that and not necessarily tying. I was like, come on, y'all. I'm gonna need y'all to think, not necessarily tying that all this data, all this information, all this stuff that y'all talking about, and all these policies y'all want to write, and all these programs that y'all want to put together, which I loved it for, because to your point about managing budget and running projects, we learned all that in my MPH program, but that's on the side. But all of that information comes from where? The coded data, the coding. So, it to me, it was a full circle, happy place. Like, yes, I did the right thing. Because it would have been easy, probably easy peasy, to just go and get a mastery level degree in something health information. But why not broaden that? Why not challenge myself and stretch that a little bit and see what's tied to it? Because there's so many, because that's, to your point, even about informatics, you don't necessarily have to be nursing informatics. It could just be informatics in general. Stretch yourself to that level, just and apply what your knowledge base and your skill base is to that. So I don't know. Yeah, I love it.
I agree. Because you don't have people who who presented that way to people.
Mm.
They don't give people options. Like they just, I just, I'm just so over the entire education system in this country. That's just it, and it just needs to be, just revamped. And I think it will be revamped along with healthcare. I think that these are the last vestiges of a dying dinosaur because it is not effective.
But I think, to your word of 2022, I think those gatekeepers are being moved out, or are retiring out, or what have you, because those are the people who control kind of where folks can move and shake and shift, even in education. Like they'll, oh well, and you even hear it, unfortunately, I guess even to this day, or you hear stories of people talk about, oh, my counselor didn't want me to go to college, or my counselor didn't think I could do this. They tried to shift me over here in domestic workers, or they tried to shift me over here in working in factories or other skills. But don't get me wrong, those skills still have some you can go far with some of those skills. And so we do need some of those trade skill things back. But I look at, for me, I look at coding as one of those trading skills. Now you build on that with the additional information that you have, and or certifications, and or um education, but it still breaks down to a skill. But you don't have someone, to your point, you need somebody to tell you, they said you couldn't do it. Yes, you can. Now you have to make sure that you're willing to read, because reading is fundamental in all of this. um and know that there's constant change in this profession. So if you're that type of person that everything has to stay the same day in and day out, this is probably going to drive you absolutely bananas. And so it may not necessarily be for you, but then you have to know you to know what it is that is for you, and what you can and cannot deal with. So I just never let somebody tell you that there's something that you cannot do, because look at us. There's always ways around all of the things. All of the things. So yeah, I love it.
People just have to, they just have to rise to the occasion, and you just have to realize you can't let anybody stop you. I mean, you don't have to be, you don't have to be mean or loud, but you just have to be assertive. And this is what I want, and if you can't help me, I'm going to find somebody who can.
Mm-hmm.
And I remember the prime example. This was years ago. I worked for this home health agency here in Pennsylvania. They were expanding into New Jersey and Delaware. So we had a little newsletter, and in the newsletter, I'm like, oh, they were paying for nurses to get licenses in those states where they needed people.
Mm-hmm.
So I'm like, oh wow, this is a chance to get a free license. Like, why the heck not? So I called the number, and when I called the number, I tell the lady, she's there. So I told her I'm an LPN. So she's, oh, I think it's only for RNs. I was like, I don't think that's fair. That is only for RNs. I said, who made that decision? So her name was Len Renke. She's the vice president, Len Renke. So I said, well, do you have her number? You just can't call the vice president. I said, no, you just can't call the vice president. So me and my industrious self, I went through, I pulled out my whole stack of newsletters. Because, back then they mailed everything.
Mm-hmm.
I found Len Renke's phone number. Same day. And I left a very nice message. I just told her that I was not pleased with what I heard. I think it's not fair, and there's no need for division, blah, blah, blah. I would love to take advantage of the opportunity. That later on that same day, the same person who told me I couldn't call Len Renke was calling on behalf of Len Renke to tell me that it was open to everybody.
You better do it. That's a whole other conversation. Advocacy. We might talk about that next week. Or not next week. We won't be here next week. The following week. That's right. We won't be here. You do. You have to advocate for yourself. But again, it starts with you knowing you. Because, you folks will be out here rah, 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 and then be like, I don't even want to do that. Then why are you out here rah, rah, rah? So, yeah. Well, I think we did good. We had a lot of tea today.
Definitely.
Even
that single path coding is something that's going to be a thing.
Sir, I'm gonna have to keep my eyes on that one. See what's happening out here in these streets. Maybe I'll start I say that I ain't gonna do that, but I might. Maybe I'll start a little LinkedIn conversation. Y'all heard about this? What are your thoughts on this? What y'all think? Where this going?
They will weigh in.
They will. You are welcome. So, Mr. Jesse, do you have any closing thoughts?
No, once again, I'm just glad to be here another week, and I wish you all the excitement and fun that you're going to have next weekend.
Well, it's going to be my book club. We're retreating. We try to do this annually. We haven't done it in the pandemic. And so we were like, we testing the waters. We're just going to do a one night retreat where a few of us get together. We're going up the state, a couple hours away, and just plug in and connect and all the things that we do at a retreat. So so I'm looking forward to that. So that'll be fun. And then um the other weekend that I won't be here, August the 20th, um um we're celebrating our anniversary early. So we're doing it that week. Our anniversary is actually August 28th, and so we're going to celebrate early. Um to undisclosed, because some folks in my house, i.e. my husband, don't even know where we going and what we doing. So it'll be a surprise for him. And Lord, I hope I don't have to kill him because of the surprise. But anyway. Oh Lord, that's a whole other conversation. We'll have to break bread on my significant other, Jesus. But anyway, so that's what's happening. But what we need to do, sir, and we talked about this last week, is possibly doing our get together in October. And so putting the parameters and maybe just even opening it up. So we're going to have a live Saturday morning tea in Pennsylvania. So in Philadelphia, or wherever it is he feels that we need to go in that area. And I know Asha said she wanted to come. I think Molly said she wanted to come. I think a couple folks mentioned that they wanted to get information and be there. So we'll work. We got to get on each other's calendars, because this one right here is very busy in doing all of the things. And we just need to get on each other's calendar and kind of strategically put all of that in play. And so, yeah, we can have like a little room and get some cameras. I bring some gear and it'll be cute. I'm excited. I'm excited. You're like, look at them creating their own little stage. How about that?
There you go.
Forget the table. We got a stage going. And maybe it'll morph into something that we'll do on a maybe quarterly basis, annual basis, semi-annual. I don't know, but yeah, we're doing that. So I'm excited.
That's right.
Another skill set, because we're gonna learn how to put together these types of things. You never know what kind of skills you can bring to the table. And if you have those skills, you might want to reach out to us. You might be able to assist us in the background, but we'll figure it out. You know me. We're resourceful. And this man right here, Lord Jesus, I've never met somebody who kind of thinks like me and be like, oh, we're gonna make this work. So it's been great. Okay, so thank you all again for joining the Saturday morning tea. Was the tea spilled today?
Absolutely.
Yes. So if this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the channel, the Professional Reimbursement Network. And you can also check out the Coding Nurse channel on YouTube. He got some nuggets over there. Don't miss out. Don't miss the boat. He just talked about analytics, and if that's where your mind is and that's where your path is leading you to, check out that video. And while you're checking it out, don't forget to like the video, put a comment in the video so others can find it. That's how this thing works. You got to engage. So, I mean, it's one thing to watch and jump on, but engagement helps push the information out further. That helps us bring folks who probably really need to hear this information, hearing the information. So sharing it either directly with them or engaging allows us to broaden our reach. And hopefully helps us have a whole great community of like-minded folks doing some of the same things. So look at me, jumped on a whole other soapbox right before at the end. So last but not least, to my Clubhouse folks, don't forget to click on the greenhouse to join in the fun in our club. As well as you see people in the room, you don't know who, what, when, where, what they bring to the table, but follow each other. It takes nothing to follow. And then, I mean, you may find out like that y'all may be following down a different path, and you can unfollow if you need to, but at least follow each other, check each other out. They're in this room for a reason. There's knowledge in this room. There are questions. There people who even may be just curious about the profession. So follow folks and follow up with them. If they reach out to you, back channel or whatever, just follow. It takes a couple of minutes to just be like, hey, I see you were in here. What do? You never know who you may meet. That's networking. That's one of the tips in the 5 steps. Networking. But yeah, okay. Let me get off the see how quick I jump on a soapbox. So also clicking on that green house allows you to be notified of our live broadcasts, which happens on Saturday mornings at 9 a.m. Eastern Standard Time. Keep in mind, we will not be here next week because I will be traveling. So again, this has been a great session. Thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
Thank you. You too.
Bye-bye.